Hello and welcome to this film, which is the second in a four-part series aimed at nurses working in the secondary care setting. We're now going to look at how we can treat VTE using anticoagulation and gain an understanding of its management. My name is Rebecca Locke, and I am an anticoagulation nurse specialist and educator in the field of anticoagulation and thrombosis.
And I'm Carol Law, and I'm a thrombosis education advisor, and I've been delivering courses in anticoagulation, thrombosis treatment and prevention for over 20 years with Rebecca. And we're delighted to be presenting this film focusing on anticoagulation and its role in the management of venous thromboembolism on behalf of Thrombosis UK and the National Nursing and Midwifery Network for VTE prevention. The National Institute for Health and Care Excellence, or NICE as it's commonly known, provide the foundation for the management of venous thromboembolism in its clinical guideline 158. If you look at this pathway, you will see that the first option in the flow chart is anticoagulation treatment, and that's what we're going to focus on today. So if you click on that anticoagulation treatment box, it will reveal this flow chart, which details NICE's guidance on anticoagulation treatment for VTE. We're going to discuss the anticoagulation treatments available and the key considerations for the care and management of a patient prescribed anticoagulation whilst in hospital. In order to do this, we need to consider what an anticoagulant is. So, broadly speaking, anticoagulants are chemical substances that prevent or produce the coagulation or clotting of blood. And sometimes they're referred to as blood thinning medicines. Although they don't actually make your blood thinner, blood just doesn't clot as so easily whilst taking an anticoagulant. And although they're used for similar purposes, it's important to remember that anticoagulants are different to antiplatelet medicines such as low-dose aspirin and clopidogrel. You'll probably have seen a variety of anticoagulants used on the wards. They can be thought of under 5 main headings. So firstly, there's low molecular weight heparin, and there are 3 that are commonly used in the UK, and these are enoxaparin, dalteparin, and tinzaparin. And it's important to remember that each one of those also has a trade name, and you'll see those in brackets. So enoxaparin is Calexane, dalteparin is Fragmin, and tinzaparin is Inahep. And we prescribe them underneath their generic name, not the trade name. Then there's fundaparinox, which is a synthetic anticoagulant. And then the third group are vitamin K antagonists, such as Warfarin, and sometimes you'll see that abbreviated to a VKA. The fourth group is direct oral anticoagulants, and these include apixaban, dabigatran, edoxaban, and rivaroxaban. And again, remember that there are trade and generic names, and the trade names are you can see in brackets. And this is really important, as this can cause confusion about whether a patient is prescribed an anticoagulant or not. And we're going to discuss this more when we talk about discharging patients on anticoagulants. And finally, there are unfractionated heparins, but they're not commonly used.
So low molecular weight heparins are anticoagulants derived from natural heparins of animal origin. So it's important to know that, because for some patients that they won't be suitable. Biosimilars are also available. An anticoagulant is a chemical substance that prevents or reduces clotting, coagulation or clotting of the blood. Low molecular weight heparins work by interrupting the process involved in the formation of blood clots. Low molecular weight heparins are used for the prevention and treatment of abnormal blood clotting in certain people and diseases, including the prevention and treatment of DVT and pulmonary embolism. Low molecular weight heparin is administered subcutaneously. You may well have heard of the clotting cascade and anticoagulation. Clotting takes place in 3 phases. The first phase is vascular constriction, where the blood vessels constrict to prevent blood leaking out of any damaged vessel. The second phase is platelet aggregation, where the platelets clump together and form a platelet plug. And the third phase is the formation of a fibrin mesh. A fibrin mesh holds that platelet plug in place. For a fibrin mesh to be created, you need to have activation of the clotting factors. The clotting cascade can look very complicated, but we're only going to concentrate on certain of the clotting factors. All the clotting factors are numbered, and just to make it more difficult, they are numbered using Roman numerals, and they are numbered in the order they were discovered and not in the order that they work. So that often makes it difficult to understand. So I'm going to give you a very simplified version. With low molecular weight heparin, it works by inhibiting the action of factor 10 and thrombin, which is factor 2. And it does that in combination with antithrombin 3. So if you look at this clotting cascade, you will see that factor 10 and factor 2 are at the bottom of the actual cascade. Warfarin blocks the effects of vitamin K, and vitamin K is needed for certain clotting factors to become activated. Those clotting factors are 2, 7, 9, and 10. And it is therefore known as a vitamin K antagonist. Blocking vitamin K prevents blood clots forming so easily by increasing the time it takes to make fibrin, which is what the mesh is made of. It usually takes about 3 days for warfarin to build up its effects, but it can take weeks or even months before the right dose for each individual patient is achieved. The relationship between the dose of warfarin and its effect on a patient is influenced by genetic and environmental factors, for example, drugs, diet, alcohol, and various disease states. Because of numerous drug interactions, it is important to check all the other medicines that a patient is taking and make sure that they always let the anticoagulation service know if those medications change. This is the clotting cascade, and on this it shows where warfarin works. So you can see it works all over the clotting factors. It works on factor 9 and factor 7 and factor 10 and factor 2, and it slows down their activation. And you'll see that after the Roman numeral, it's got a little A for activated. The direct oral anticoagulants help inhibit clot formation by preventing thrombin from working, which then prevents fibrin from being made from fibrinogen. Apixaban, edoxaban, and rivaroxaban work directly on factor 10A and inhibit its action. They are therefore called factor 10A inhibitors. Dabigatran binds to thrombin, which is factor 2, and is known as a direct thrombin inhibitor. All 4 medicines work quickly within 2 to 4 hours, and most of the drug is excreted by 24 hours. Unlike warfarin, they don't require regular anticoagulation level monitoring with an INR, and they have fewer drug interactions than warfarin. You can see on this version of the clotting cascade where the oral anticoagulants work. So the factor 10A inhibitors obviously work higher up than the direct thrombin inhibitor, which works on factor 2 or thrombin. This slide shows the indications for what DOACs can be prescribed for. It's very important to realise that DOACs are very specific and cannot be used in all conditions requiring anticoagulation like warfarin. So they're very specific. So you can see that all 4 DOACs, apixaban, dabigatran, edoxaban, and rivaroxaban, can be used for the treatment of DVT and PE and the prevention of recurrent DVT and PE. When it comes to the prevention of DVT and PE in adults undergoing elective hip or knee replacement surgery, only 3 of the DOACs can be used. They are apixaban, dabigatran, and rivaroxaban. For the prevention of stroke and systemic embolism in non-valvular atrial fibrillation, you can use all 4 of the DOACs, apixaban, dabigatran, edoxaban, and rivaroxaban. Whereas for the prevention of atherothrombotic events after acute coronary syndrome with elevated cardiac biomarkers, only rivaroxaban can be used. Therefore, you need to make sure that you check the licenses, the SMPCs for each of the DOACs when you are using them. When we think about DVT and pulmonary embolism, we need to consider whether or not it's provoked or unprovoked VTE. It is important to identify if a VTE is provoked or unprovoked, as this is important in deciding how to manage the patient's treatment. A provoked VTE occurs when there is an identifiable cause for the event. This can be as a result of transient reversible factors or continuing irreversible factors. For example, transient reversible factors would be surgery or hospitalization, whereas continuing irreversible factors would be cancer. Unprovoked or idiopathic VTE is said to occur when there is no identifiable cause, so we don't know why the patient has had the VTE. When we consider the duration of treatment, it is important to identify if a VTE is provoked or unprovoked, as this informs us of the likely risk of recurrence and duration of the anticoagulation. Patients with unprovoked VTE are at an increased risk of recurrent VTE, so to prevent recurrence, clinicians should consider long-term anticoagulation, and they should balance that against the bleeding risk of the patient's preference, and their lifestyle should be all considered when making these decisions. For provoked VTE, because it's going to be possibly transient, then NICE considers stopping anticoagulation treatment after 3 months. However, with active cancer, that could be 3 to 6 months. After a provoked DVT or PE, if the provoking factor is no longer present and the clinical course has been uncomplicated, then you can stop as indicated above.
So in order to ensure that patients on anticoagulants are managed appropriately, it's really important to ensure that all patients diagnosed with a new VTE should be referred to an anticoagulation service. And the quality of the referral is vital to support the anticoagulation's decisions. So we must make sure that that information is accurate and complete. So the information that the anticoagulant service needs includes the anticoagulant that the patient is taking, the dose of the anticoagulant. If it's warfarin, they will need a record of the INR. If it's a DOAC, the date that the DOAC was commenced, and if it's one that requires a dose reduction, then that date needs to be included. If the patient was on taking low molecular weight heparin and it's been stopped, when was it stopped? If there are any known bleeding risks, these need to be included, and also any other medication or medical conditions that might influence the anticoagulation decisions. And they would also need to know the social history and cognitive abilities of the patient. Also included some baseline blood tests such as liver function test and renal function. And this is particularly important if your patient's taking a DOAC. And then, as Rebecca's just describing, whether that PE or DVT is provoked or unprovoked, because that is going to influence long-term decisions. So in this slide, you can see the key factors to be included in the management of patients on the ward who are prescribed an anticoagulant. And as we've just been discussing, referral to the anticoagulant service is an important part of that. And that might be either within the hospital or as an outpatient. You will also need to be making sure that the patient's INR is being monitored if they're on warfarin. You'll need to make sure that the anticoagulant is prescribed appropriately, that it's administered appropriately so that the correct dose is given at the correct time, that if the patient has had surgery, that it's restarted appropriately if it's been stopped during that time, that you're looking out for any side effects of anticoagulation, particularly bleeding and bruising, and that the patient receives appropriate education about their anticoagulation and how to administer low molecular weight heparin if they're going to be taking that at home. So this is this is why that preparing a patient for discharge on anticoagulation becomes very important. And we're going to talk about that specifically in the fourth film in this series, and think about things like the information, the community service that are that might need to be informed, any transport, the actual medicines that are being taken home, and whether an anticoagulation appointment has been made. However, you'll remember that on that first slide we saw showing the management of VTE, after the anticoagulation box, there were some other headings. So we do need to have a look at some of the other factors that influence the management of VTE. So it can be very painful. So you need to think about the analgesia that your patient has been prescribed. They might want to know what exercise they can do, how much they can do. And if you look at the Thrombosis UK website, you will find there's a short video showing some suitable exercises for patients that you can look at yourselves and you can refer your patient to. We're increasingly aware of the need for appropriate psychological support for patients, particularly those who have had a PE where there might have been issues in terms of their diagnosis. It can be a very scary thing for patients, so we need to make sure that they know where support is available, and a really good starting point is clearly Thrombosis UK for patients. And then there are some mechanical interventions, some things that can be given to help patients care that aren't anticoagulation, and these include elasticated graduated compression stockings, and you need to look at your local policy to see how should be used in practice. Intermittent pneumatic compression, which you will probably be familiar with if you're working on a surgical ward or in theatre, because that's where they're often commonly used. And then there's a procedure called percutaneous mechanical thrombectomy. And we need to make sure that we know what might have caused the VTE. So for patients with an unprovoked VTE, they might have a hidden cancer, and so that should be investigated. And also for some patients, thrombophilia screening is appropriate. And as well as that, we need to make sure that people have appropriate information to help increase adherence and reduce patient anxiety. And that should be both written and verbal, and we're going to discuss that in more detail when we talk about discharging patients on anticoagulants.
So a new policy is that low-risk pulmonary embolism patients may be managed at home. In the past, all pulmonary embolism patients were admitted. But there is a scoring system called the PESI scoring system, which on diagnosis of patients will be risk assessed into high or low risk pulmonary embolisms using this PESI scoring system. If they are high risk, they must be admitted. If they are low risk, they can be considered for discharge. We will look at that in a bit more detail in the fourth film when we talk about discharge. But I think it's important to note that on top of clinical indications, the ward staff should also consider other factors such as social and psychological factors. So, for example, the level of the patient's compliance, either as a result of their cognitive ability or just because whether or not they buy into the treatment. Family and social background. Do they have carers at home or do they live alone? Are community support services available? Is there appropriate transportation and access in an emergency back into hospital? And as I said earlier, their cognitive function and their ability to get help if they require it. So, for example, they must know what the symptoms are of that pulmonary embolism extending and their situation getting worse and their condition getting worse. So it's not just as simple as doing a clinical risk score. And I think this is very much where nurses come in, because they're the people who remind the clinicians that this patient should be looked at in a holistic manner.
So NICE have written some quality standards for VTE treatment and prevention. And what they've done is they've amalgamated the standards for VTE treatment and treatment and the prevention of hospital-acquired thrombosis, so that they now make one set of 5 standards. And these were published in 2021 as Standard 201. And it's the 4th standard that relates to anticoagulation, which states People aged 18 or over taking anticoagulation treatment after VTE have a review at 3 months and then at least once a year if they continue to take it long term. So this is very clear that referral to anticoagulation service and their ongoing management is very important if we're going to meet this standard. On this slide, you can see the references that we've used. So if you pause the film, you may want to take them in more detail. Those are the references that we've used. And here we have some learning resources that you might want to link to in order to have a little bit more detail about anticoagulation and some of the other issues in terms of the management of VTE. And this slide shows some activities that you may wish to complete in order to assess the quality of anticoagulation treatment locally in your clinical areas. So you can review your local protocol for the management of VTE and see whether it reflects the most recent guidance provided by NICE in their guidance 158, because this is what underpins the management of VTE in hospital. Have a look and see which anticoagulants are used for the treatment of VTE in your trust, and make sure you're familiar with the generic and trade names so that if a patient comes into hospital and into your ward, you know which anticoagulant they're taking and there's no risk of double prescribing. You need to have a look at your local protocol for referral of patients requiring anticoagulation to the Anticoagulation Service, to ensure that we can meet quality standard 201, and think about whether what information your patients are being given and the leaflets that are available in your trust, who's responsible for giving them to patients, and who's responsible for prescribing anticoagulation to inpatients in your trust. And then to think about whether you have a protocol for early discharge of low-risk PE, because as Rebecca was saying, there are some key factors that we need to consider to make sure that low-risk PE is managed safely.
So I hope you've enjoyed this second film in the series, and we hope that you will join us again for film 3 and for film 4. Until then, thank you very much for listening. Bye-bye.
Bye-bye.